All right, let's move on to our other big focus for this evening. A third case of monkeypox has been reported in Delhi. The total tally of cases across the country now goes up to 8. States and the centre are stepping up preparations to tackle monkeypox. But amid that, Union Health Minister Mansukh Mandaviya addressed the Lok Sabha on this issue as well, urging people not to panic. Mandaviya said that the vaccine research is underway and explained that monkeypox is very similar to smallpox. Meanwhile, on the other hand, after meeting with Union Health Minister Mansukh Mandaviya, Serum Institute CEO Adar Poonawalla has said that research for the vaccine is currently underway and all preparations for that is being done. Let me welcome our guests who are joining us this evening. Dr. Ishwar Gilada, Secretary General, Organized Medicine Academic Guild is with us, and Dr. Subramaniam Swaminathan, Director, Infectious Diseases, Global Hospitals, is with us as well. Thank you so much, both of you, for joining us. Dr. Swaminathan, let me come to you first. As far as monkeypox is concerned, yes, there are just about 8 cases, but there is still a lot of fear right now surrounding monkeypox and the worry that what if it spreads and we see a massive, now that we're just coming out of COVID, what is your own assessment of the situation and how concerning is it?
Obviously, something that's new and something that we are not familiar with is always anxiety provoking. But I think that's where information and data is important to fight that. And we should understand that this is something that we have known for a couple of decades at least, as far as monkeypox is concerned. And the second thing is this current outbreak is not 1 or 2 days old. It's been going on for a couple of months all over the world. But they have been able to handle it to a good extent. Obviously, we are still not completely on top of it. But it's not like COVID where it is literally run amok. So obviously, it's not a high-intensity situation where you have a lot of people falling sick and a lot of people dying and things like that. So obviously, it's important for us to understand our problem correctly, calibrate our measures, and proceed accordingly. And panic is not the way forward. And as of right now, it's still a very small problem compared to what else is happening in the country. Please understand, more people are falling sick and dying of, say, tuberculosis and malaria and possibly even COVID at this point of time than monkeypox is. So yes, it's a challenge, but it's not the most important challenge in front of us just now.
Okay. Dr. Gilada, your view as well here in terms of how serious the situation is, because if we just look at what we saw in COVID, at least in each wave, India always seemed to be lagging behind what was happening in the West. So after it happened in the West, the wave sort of ebbed over there. Then we saw the wave sort of pick up in India. Do you see a similar sort of pattern? Do you think that we're going to see a sudden spurt in cases going forward?
Avni, thank you very much for having me on the show. India would like to maintain that pattern, lagging behind. And if we see currently, we have seen that a virus coming from a small place like Wuhan had put us on knees for 2.5 years. So we cannot neglect monkeypox, will not do that. Similar situation was there with HIV, almost 1981. 6 cases were diagnosed in California, and they were all gays, and that was sexual transmission. And they realized that some new disease has come, giving pneumonia and Kaposi sarcoma. But thereafter, it became heterosexual. It ravaged all over the world. Currently, also, what India is doing is following what WHO is saying. We should be thinking out of the box. WHO may have its own compulsion, not calling it STD or sexually transmitted infection. We should be able to call spade is a spade. Currently, 100% cases which are seen in this outburst are all sexual transmission. 98 to 99% of them are in MSM, that is male sex with male, 1% in female. And there is not a single case which is fomite transmission or respiratory droplet transmission. So what people are doing basically, say in a highly educated state of Kerala, they said that we have a roadmap of a person who died of monkeypox. So taxi driver, bus driver, his accomplices from flight, healthcare workers, doctors, all are quarantined. This is nonsense. You know, how can we do this when it is not transmitted by any of the touch, any of the fomites? So just because we are going through COVID currently, it doesn't mean that every new disease is coming is like COVID. Now, secondly, India has been a vaccine capital of the world, pharma capital of the world. For last 2 months, I have been saying that we should reactivate our machinery for making a smallpox vaccine, which provides 85% protection to prevent, and it also is useful to treat monkeypox and many other 11 other poxes. So currently the good platform is modified Vaccinia Ankara MVA. We are in touch with even a scientist who has a platform to develop that. He is in Italy, called Dr. Sicardi. So I think we should be proactive. It may not be much useful to India at present, but it will be useful to the rest of the world. And lastly, unless until we categorize this as a sexually transmitted infection, we cannot be categorical how to respond to it. Otherwise, we are in wilderness. We are thinking that whole country will get. It is not possible. So it is only sexual transmission. Only those which people below 45 or 42, they are vulnerable. All above 42 have been already vaccinated with smallpox, and they have a immunity, almost lifetime immunity. And those which are having multiple sex partners, MSM, hijras, sex workers, they need to be seen. And firstly and foremost, we should change the name of disease called monkeypox. It is no more transmitted from monkeys. It is from human to human. And it is dehumanizing to call something like monkeypox. People and doctors will ask a patient, have you done some monkey tricks to get monkeypox? So I think we should change nomenclature. Even if WHO doesn't want to change, we should unilaterally change in India. World will follow.
Absolutely. In fact, Dr. Swaminathan, if like Dr. Gilada says, this is a sexually transmitted disease, and we should really call it that, the protocol then that is being put in place right now is obviously not going to work. The kind of contact tracing that we are seeing, the states being advised that the center is putting into place, what should then be the protocol?
I think it's safer to cast a wider net simply because we don't know everything about it at this point of time, number one. Number two, nosocomial transmission or hospital-based transmission to healthcare workers has been clearly documented in the past. Number three, it's ultimately a zoonotic disease. It's something that's come from animals to us. And there have been outbreaks in the US from obviously imported animals, which has resulted to transmission to other animals within their territories, and that's been controlled. So obviously, there's a lot more that we don't know. So at this point, I would still prefer being a little cautious and trying to get as much data as possible so that we can recalibrate our efforts in a more science-based manner. Yes, we have got a lot of information, like Dr. Gilada pointed out, in terms of the risk factors being people who have significant immune suppression are obviously very high risk when it comes to life risk and mortality and things like that. But I think there is a lot more we still haven't learned, because there is some early data to suggest that our strain may be slightly different from the Western world, in which case, how did it get here? When did it get here? Have we been having transmission here for some time at least? So a lot of unanswered questions. And I, for one, would prefer to wait and watch and go with the science as we start getting more and more information.
Dr. Swaminathan, just to take that point forward, in terms of the kind of cases that we've seen so far in India, we've seen about 8 cases. But do you think somewhere, people are not, because of the stigma that is attached to monkeypox, people not coming out and getting tested, and there could be cases, many more cases lying, undetected?
I think that's an important point. In fact, we've had this problem world over, for that matter, with every outbreak, in that there is a lack of information and a lack of decentralization. I think it's important to decentralize the whole process. We need to have expert testing facility at least every state level, and we need to have good training of doctors at various levels so that they can identify the cases very early. And we need to have, a very structured pattern of testing and referral up. I think we are starting to do that, but this needs to be ramped up at rocket speed, simply because we don't want to miss cases and we don't want to miss the chance of containing an outbreak wherever it may happen. So I think there are certain things we need to do. I know the government is working on some of these things. I would like to see a little more speed and haste in this, at least in certain directions.
Yes, fair enough. Dr. Gilada, just to, talk about some of the questions that usually come up when it comes to monkeypox in terms of the kind of cure, the treatment, these are some of the usual questions that are coming up at this point in time. What can you tell us?
See, currently there is no perfect antiviral available. There are 2 of them or 3 of them licensed in America, 1 of them licensed in India also. One is a ticovirimat, second is a brim pseudofovir and pseudofovir. Brim pseudofovir has been used for herpes infection, herpes simplex infection, and pseudofovir has been used for CMV infection in India. And that is basically injectable, used for CMV retinitis, where there's a blindness caused in HIV. Apart from that, smallpox vaccine has been therapeutic also. So this vaccine can prevent, and this can be also useful for treatment. Otherwise, we need to have only symptomatic treatment. Pain has to be treated with painkiller. Fever has to be treated with anti-fever medicine. There will be a lot of fluid loss if there are a lot of pox marks are there. We need to treat that as burn cases. So, and some secondary infections are there. We have to treat accordingly. But what is more important, I would like to again concur with Dr. Swaminathan said, that yes, we should go by science. I will go one step beyond. I will say science, statistics, and logic. Medical science believes in one thing: common things are common and rare things are rare. What is common in current epidemic or this outburst is sexual transmission. We are not giving any heed to that. We are talking in wilderness. So basically, have you heard any time that people or sexual contact of those people who are found positive has been traced? Nothing. So we are talking about very, very remote contact. Same thing which has happened in HIV, in syphilis. HIV, though is STD, it can be transmitted from mother to child from blood transfusion. Syphilis can be transmitted from mother to child and blood transfusion, but we do not stop it calling from STD. So they are accidental transmission. So similarly, needle, prick, this, we have been people all scared about HIV transmission like that, but very rare to get from needle pricks, etc. So similarly, monkeypox is not transmitted. If you read the guidelines of WHO, they are so much misguiding that housekeeping industry, if you are coming in touch with towel or bed sheet or personal contact, so this is all rubbish. This is important provided you have talked about sexual transmission. You are not talking about sexual transmission. You are not talking about risk groups. You are not talking about handing over the entire program to agency like National AIDS Control Organization. I'm not from NACO. I have no connection with NACO. But what I'm saying that we have established agencies which are looking after very well the program. There are more than 2,000 ICTC, that is Integrated Counseling Testing Centers. There are 1,050 ART centers. And the entire machinery has also good partnership with key populations like sex workers, Hijra community, MSM people. So you work through them. Peer group modeling, that will only save our country. Otherwise, we are talking something which is not present and will be missing cases. There are people who are going underground because it is called monkeypox, number one. Number two, it is sexual transmission. Number three, it is MSM. So all three are causing stigma. I have two patients, they have not come forward. They don't want to come and meet me. The first one was saying that, doctor, I don't want to be first case of monkeypox in the country. I know him for last 2 months. I've been treating him when he was shipped. So people will go underground. And we need to stop hounding. Now, central team is going to Kerala. What is central team going to do there? Yes. It is not a monkeypox tourism at all. So I think we should have a different approach at all, out of box thinking. Otherwise, we are making the same mistake what was done earlier. For earlier diseases, and other countries, they are doing this.
Right. So, Dr. Swaminathan, what in your view needs to be, the few things that one should be aware about from what we know about monkeypox and the precautions that one should take?
Okay. So the answers for that are fairly simple. Number one, the risk of developing monkeypox as of today is still astronomically low for the individual person. Number two, if you have fever and a blistering rash, especially on the extremities or the genitalia and the face maybe, and you have contact with somebody who has had monkeypox or has returned from the US and things like that, or returned from overseas, then that's the kind of situation where we start worrying about monkeypox as of today. We do not know as yet if endemic transmission or local transmission has started off, or if so, at what level. So the risk is still very, very low. Second, please note that the risk to life is astronomically low. We have had many thousands of patients infected worldwide, and the number of deaths are still very, very low. And it's mostly a problem for those whose immune system is extremely delicate. So there's absolutely no reason to get panicky or to get worried about it. Yes, it's concerning, but there's no reason for panic. And third, if you have issues like this, please make sure that you reach a good hospital and make sure that they follow the due precautions and the guidelines that have been laid out in terms of testing for this. It has to be sent to a reference lab for this to be clearly identified and isolated. And obviously, we need to know more about it to see if it is part of the same chain or whether it's an independent event and so on and so forth. Right. So for the general public, as of right now, it is interesting. It is something that they should remain vigilant about, but not yet a reason to panic.
And Dr. Swaminathan, in terms of the vaccine itself, how is that going to sort of pan out? Yes, it is in the works, but will it need to be sort of a mass vaccination that needs to be carried out, or what would be then the protocol?
that's tough because please understand that if you look at the 2003 outbreak in United States and Midwest, more than 40 confirmed cases, 72 probable cases, but they controlled it without any such measures, with just good contact tracing and epidemiological measures. So they were able to do it. And remember, their local flora, the ground vole or the ground squirrel, something, that also got infected. So they managed to control it. So it is not impossible. But the question is bigger than that. The question is, how long has this been going on? And do we have local transmission? And do we have local reservoirs and things like that? So without knowing all of that, I think it's very difficult to say that. The second thing is that developing a vaccine is not easy. The science is great, but we still need to do a lot of studies and testing and things like that. And how do you prove efficacy of a vaccine when a disease is still very, very rare? So obviously we need to do the research. We need to be ready. We need to have something that can be deployed very quickly and mass produced. But we are not yet at the point where we need to reach for the vaccine. Please note that none of the countries are as yet looking at vaccination as a way out, even in countries where the numbers are rising. It could be an option for people who have been exposed recently. So if you've been around somebody with high degree of contact with somebody who's had monkeypox, as a post-exposure prophylaxis, then maybe a vaccine could be part of the answer. But I think there is more that needs to be done, more work that needs to be done, and vaccine could be part of the answer. But I don't see it as part of the answer as of today, but it's good to be prepared for it.
All right, fair enough. Thank you very much, Dr. Swaminathan and Dr. Gilada, for joining us and busting some of those myths and helping us understand more about monkeypox at this point in time. But on that note, we're completely out of time. Thank you so much for joining us on this edition of the Urban Debate.